بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, this is one of the important lectures in the abdominal imaging dealing with the adrenal glands. And this is a very important subject since it will handle some of the particular issues concerning this very important gland. You know that the word adrenal means that the structure is adjacent to the kidney, and this structure is evaluated by ultrasound, evaluated by CT, and also by MRI. Then the adrenal gland is in the form of an inverted Y configuration. It is seen in the retroperitoneal space just above the upper wall of the kidney, and there should be some adequate retroperitoneal fat so that you are able to see the adrenal gland. And that's why in thin persons and the children, you cannot usually appreciate the adrenal gland because of the paucity of the retroperitoneal fat. This is the normal appearance of the adrenal gland, as I said, an inverted Y configuration. The adrenal gland is composed of a cortex and a medulla, and the cortex is formed of three layers: the zona granulosa, the zona fasciculata, the zona reticularis, and all these three zones will form the cortex, while the core of the gland will form the medulla. Of course, you cannot discriminate the cortex separable from the medulla by imaging. The cortex has the function to uh, uh, secrete aldosterone, cortisone, and the androgens, while the medulla is concerned with the secretion or the synthesis of catecholamines, uh, especially the adrenaline, which controls the blood pressure, the heart rate, as well as the sweat glands. As I mentioned, that you can examine the adrenal gland by ultrasound, by CT, by MRI, and we may have some of the interventional techniques, like you may have a CT-guided needle biopsy, for example, from a suspicious adrenal mass. Then there is no special preparation for evaluation of the adrenal glands by CT or by MRI or by ultrasound. By CT, you may have the scanogram, and you specify the area to be scanned from the cupula of the diaphragm down to the iliac crest, and you have the intervals at 1 centimeter, except in the region of the adrenal gland you should have thin slices in the range of 2 to 3 millimeters. And you may also reconstruct the images in the coronal like this or in the sagittal plane. The normal appearance of the adrenal gland is like an inverted Y configuration. It has a main stem, a lateral limb, and a medial limb. And this is the same on the right side, except for that many times you cannot see the lateral limb of the right adrenal gland because it is adherent to the adjacent liver. Then in the coronal reconstruction or the coronal images by MRI, you see the same configuration, an inverted Y along the upper pole of the kidney. This is the left suprarenal gland, and this is the right suprarenal gland. By MRI, this is an MRI contrast enhanced T1 weighted images and with fat suppression as well. Then you see the adrenal gland on the right side, showing the typical configuration. The adrenal pathology we would like to handle include the adrenal masses, the differential diagnosis, adrenal hyperplasia, adrenal cysts, hemorrhage, and infection. Of course, the masses um, are multiple, and they include the adenoma, the pheochromocytoma, the adrenocortical carcinoma, the adrenal metastasis, lymphoma, and the myelolipoma. Starting first by the adrenal adenoma, and we have what's known as the regular adenoma, which is divided into two major categories, the lipid-rich adenoma and the lipid-poor adenoma. Also, you have the functioning adenoma and the non-functioning adenoma. The functioning adenomas are encountered in cases of Conn syndrome or hyperaldosteronemia and the Cushing syndrome. So in order to diagnose the commonly seen adrenal adenoma, which is the lipid-rich adenoma, there are certain criteria for the diagnosis. These adrenal adenomas in general are common, representing about 8% in autopsy series. And the lipid-rich adenoma is usually of low density on the non-contrast CT images, and it will enhance whenever you inject contrast material, then the enhancement will wash out in the delayed film or in the delayed scans. Then it is stated in the literature, in order to be sure that you are diagnosing a lipid-rich adenoma, a density less than 10 Hounsfield unit on the pre-contrast CT images has a diagnostic specificity reaching about 100%. And if the density is in the range of -10, below 0 or around 0, this is almost specific for the microscopic fat. Then, in order to diagnose the lipid-rich adenoma, which is the well-known form of the adenoma, then you have the pre-contrast CT scan, then you inject contrast media, then you have a delayed 10-minute scan after injection of contrast. And here is an example. You see, this adenoma measures minus 12.8 Hounsfield unit in the pre-contrast study. And after injection of contrast, it will enhance similar to any other structure, which it does not have this enhancement has no effect on the diagnosis. But which is very important is the washout of the contrast seen in the delayed scans taken 10 minutes after contrast injection. And you see here the CT scan of a suprarenal adenoma on the right side showing a relative hypodensity. Then in order to be sure that this is a lipid-rich adenoma, there are some ways. One of these ways is to have the out-of-phase MR scanning, which are specific for the microscopic fat. Look at this example. There is a small adrenal adenoma on the right side of relative hypodensity. In the T1, it shows low signal. In the T2, it shows intermediate signal. In the out-of-phase image, you see marked drop of the signal characteristic of the presence of microscopic fat, denoting that this is a lipid-rich adenoma. Then, for the confident diagnosis of lipid-rich adenoma, you need one of the following, or you need some of the following. Number one, density less than 10 Hounsfield unit on non-contrast CT scan. Normal enhancement in 1 minute scan. with significant washout on a 10-minute scan. This means that in order to scan the region of the suprarenal gland by CT, first you have a scan without injection of contrast medium. Then you inject you measure first the density of the suprarenal mass in the pre-contrast scans and inject the contrast and measure the density of the gland after contrast injection. Then wait for 10 minutes and scan again the suprarenal gland and measure the density of the gland in this delayed 10-minute scan. Also, one of the helpful criteria or the helpful imaging is the MRI T1 out of phase, where you got marked drop in the signal of the mass in the out of phase images. Then let us look at this example by CT. There is an adrenal mass on the right side. The density in the pre-contrast scan is 6 Hounsfield unit. Then after injection of contrast, it is 60 Hounsfield unit. And in the delayed 10-minute scans, it is 27 Hounsfield unit. Then if you see in the delayed scan, there is decreased enhancement or washout of contrast by more than 60%, then this is the diagnostic sign of a lipid-rich adenoma. And the pre-contrast density is around 0, plus 10, minus 10. After contrast injection, the gland will enhance similar to any other structure, but in the delayed scan, the gland will wash out the contrast by more than 60% compared to the initial post-contrast scan. And here is an example of adrenal adenoma on the right side. This is T2 weighted image, and this is the adenoma, this is the inferior vena cava, and this is the aorta. In the T1 out of phase images, you see marked drop of signal of the lesion, diagnostic of lipid-rich adenoma. Then you try as much as you can to diagnose this lipid-rich adenoma by the two ways I have mentioned, the CT scan and the MRI. In the CT scan, you use the criteria of pre-contrast density and the washout of contrast in the delayed scan. By MRI, you use the criteria of drop of signal in the out of phase T1 weighted images. Another form of adrenal adenoma, which is known as the lipid-poor adenoma. This represents about 30% of the adenomas, which will behave as follows. Number one, in the pre-contrast scans, the density of this adenoma will be higher than 10 Hounsfield unit. If you inject a contrast, the adenoma will enhance similar to any other structure. But in the delayed 10-minute scan, there is washout of contrast by more than 60%, similar to the lipid-rich adenoma. Then the only difference between lipid-poor and the lipid-rich adenoma lies in the pre-contrast scans, where the density is higher than 10 Hounsfield unit. Then look at this example. This is a pre-contrast scan, and after contrast, then the delayed scan. The kidney has two big simple cysts, but our concern is here in the adrenal mass. In the pre-contrast scan, the density is 16, and this does not fit with lipid-rich. Then after contrast injection, you got 112 Hounsfield unit, and in the delayed 10-minute scan, you see washout by more than 60%. And this is what we call lipid-poor adenoma. Then if you see an adenoma like this with density minus 19, then you feel that you are dealing with a lipid-rich adenoma. And also you should consider that you cannot see macroscopic fat within the gland, like this fat, for example, or like this fat. I mean, you see microscopic fat guided by the density of the lesion. Then after enhancement, you follow the same rules. Okay, in this example, this patient had nephrectomy for renal cell carcinoma, and we used to diagnose any lesion in the body as metastatic deposit until proved otherwise, except in this adrenal area. In the adrenal area, if you succeeded to diagnose lipid-rich adenoma in the adrenal gland, you can safely exclude the possibility of metastasis, even if there is a non-primary malignancy uh, in this case. Then this patient had a renal cell carcinoma and had a suprarenal mass on the right side, but the density of the mass is minus 4.5, making the diagnosis of lipid-rich adenoma is more likely than metastatic deposit. Then the adrenal adenoma is a well-defined lesion in the suprarenal gland. If the density is around 0, minus 10, plus 10, you may think of lipid-rich adenoma. But if the density is higher in the pre-contrast scan, lipid-poor and the other suprarenal masses are included in the differential diagnosis. You can include metastasis, carcinoma, pheochromocytoma, granulomatous disease, as well as lipid-poor adenoma. Then if you have a suprarenal lesion and you succeeded to diagnose this as lipid-rich adenoma following the rules of CT and MRI, then the differential diagnosis is stopped here. But if you fail to reach this diagnosis, then you are in the course of a big list of differential diagnosis, including most of the suprarenal gland pathology. Then here is a lesion in the left suprarenal gland with a pre-contrast density around 45 Hounsfield unit, meaning that it is not by any mean a lipid-rich adenoma. Then you go in the differential diagnosis. It may be lipid poor, it may be adrenal metastasis if there is a non-primary malignancy, or adrenocortical carcinoma, or pheochromocytoma if the clinical picture can fit with this diagnosis. Then I mean that if you see a suprarenal mass and this mass does not fulfill the criteria of a lipid-rich adenoma, then the differential diagnosis is wide, including lipid-poor adenoma, adrenal metastasis, adrenocortical carcinoma, pheochromocytoma, and granulomatous disease. And this is an example. You see a mass in the left suprarenal gland, and the mass is relatively dense. It contains calcium. Then you think of an adenoma, but you should include the rest of the possibilities I have mentioned. And of course, to reach the diagnosis, you should combine the clinical, the laboratory findings, and many times you need the help of CT-guided or imaging-guided biopsy to reach the final diagnosis. This is the appearance of an adrenal mass or adenoma by ultrasound above the kidney, and this is the appearance by CT, and you see a relatively enhancing mass in the region of the left suprarenal gland. But in this appearance, this is T1 and this is T1 out of phase, and you see a lesion in the left suprarenal gland, and in the out of phase images, you see marked drop of signal. Then you are in the diagnosis of lipid-rich adenoma. The Inconce syndrome means that there is excess mineralocorticoids produced in the blood, and this is usually caused by a functioning adrenal adenoma in about 70% of cases. But adrenal hyperplasia or carcinoma may contribute for a minor percentage of this disease. In this CT scan, and you see this adenoma in the left suprarenal gland, and then the adenoma in the suprarenal gland may be lipid-rich and is functioning, and may be lipid-poor and is also functioning. Then it does not mean that the lipid-rich adenoma is an innocent lesion which do not produce any symptoms. It may be functioning, and if it is functioning, it will produce one of two, either the Conn syndrome or the Cushing syndrome. Then the presence of hypertension and hypokalemia in a patient with an adrenal mass or adrenal adenoma is almost diagnostic of Conn's syndrome. Then if you see a mass in the suprarenal gland like this one, and you know from the history and the clinical data that the patient is hypertensive and he has also hypokalemia, then you think of Conn syndrome, which the adrenal adenoma is responsible for this syndrome in about 70% of the cases. Aldosteronoma, meaning that the adrenal adenoma, which is secreting aldosterone, is usually unilateral, and it ranges between half centimeter and 2.5 centimeter. And if you cut this adenoma, the cross section will be golden yellow, meaning that it is rich of fat. And Cushing syndrome is caused by the excess glucocorticoid production, and also in 70% of the cases is caused by ACTH overproduction, very commonly by the or one of the causes for this abnormal ACTH production is the pituitary adenoma central or functioning adrenal adenoma in about 20% of the cases. And also you remember that adrenocortical carcinoma and adrenal hyperplasia may contribute to some of the functioning syndromes. And also this Cushing syndrome may be the sequelae of bronchial carcinoid or small lung cancer, which contribute also to the increased ACTH production. Then you see in this MRI T1 weighted image a mass in the region of the left suprarenal gland, and this is a patient with chronic abdominal pain. The patient had a medical history of type 2 diabetes, hypercholesterolemia, and hypertension. The MRI showed about 4 centimeter enhancing mass in the left suprarenal gland. This is T1 and this is T2 and this is T1 post contrast. And these are the data of the Cushing syndrome. You all know, of course, the truncal obesity, the buffalo hump, the moon face, skin bruises, and purple stria, hirsutism, diabetes, hypertension, irregular menses, and the emotional disturbances. Then we came to the issue of the adrenal hyperplasia, and if there is overstimulation by ACTH produced by the pituitary adenoma, the adrenal glands may be hyperplastic. And the hyperplastic adrenal glands are enlarged, but in most of the cases, they maintain their normal configuration. Then also hyperplasia can be a normal aging process of the adrenal gland. And you know that the aging process everywhere in the body is in the form of atrophy of these organs, like the pancreas, for example, and the brain. But in the suprarenal gland, it is in the form of hyperplasia. And sometimes this hyperplasia is stress related to due to physiologic release of the ACTH. Then hyperplasia is usually affecting both sides of the gland, both glands, but it may be not symmetric. Like in this example, you see the right suprarenal gland is prominent. It is maintaining the normal inverted Y configuration, and on the left side, it is more enlarged, and it lost some of its normal configuration. Then the adrenal hyperplasia is usually bilateral. If it is unilateral, you can see differential diagnosis like adrenal adenoma, for example, adrenal hemorrhage, and the normal aging process as well if the lesions are on both sides. One important issue is to remember that the adrenal gland may look normal in size and configuration, but actually it is hyperplastic or metabolically hyperactive, as you can see here in the PET-CT scan, where there is considerable uptake in both suprarenal glands in spite of being almost of normal size and configuration. And this is a case of adrenal hyperplasia on both sides. And you can, in a patient with Cushing syndrome, you see the fatty infiltration of the liver, the excess intraperitoneal fat as well, secondary to the Cushing disease. Then we came to the Pheochromocytoma, which is a tumor affecting the adrenal gland, and the role of 10% is well known in this particular lesion. 10% of the lesion are bilateral, and 10% are malignant. 10% occur in the pediatric age group. 10% occur outside the suprarenal glands. 10% have a familial predisposition, and 10% are not associated with hypertension. Then if you see a lesion like this, and you can see that there is a suprarenal mass on the right side posterior to the IVC. A suprarenal mass together with the presence of hypertension and the elevation of the catecholamines in urine or in the plasma is almost diagnostic of a pheochromocytoma. And the coronal CT reformatted images after contrast injection showing a right suprarenal mass representing a, a pheochromocytoma in this patient with hypertension and elevated catecholamines. And if you see a mass in the suprarenal gland, and this mass does not fit with the diagnosis of lipid-rich adenoma, then the differential diagnosis is wide, including lipid-poor adenoma, pheochromocytoma, adrenocortical hyperplasia, adrenal metastasis, and granulomatous disease. And this is a pheochromocytoma, a mass in the region of the left suprarenal gland. And the clinical picture of hypertension and elevated urinary vanillyl mandelic acid with an adrenal mass makes the diagnosis of pheochromocytoma is almost certain. Then the pheochromocytoma is a rare tumor, is not common. And some of the literature says that the injection of contrast media may be contraindicated as it may predispose to a hypertensive crisis, but as you can see, most of the cases are injected with contrast material. And also, they said that don't go for CT-guided needle biopsy for the same cause. And as I have mentioned, if you have the classic criteria, a patient with hypertension, increased vanillyl mandelic acid, catecholamines in the urine and in the blood, and you have a suprarenal mass, then the diagnosis of suprarenal pheochromocytoma is almost certain. You know that 10% of pheochromocytoma can be bilateral, and this is a small lesion on the left side and a larger lesion on the left side. And as I have mentioned, the differential diagnosis of any mass which does not fulfill the criteria of lipid-rich adenoma will include pheochromocytoma, metastasis, carcinoma, and so on. And this is a lesion which is affecting the right suprarenal gland by ultrasound and by CT, and this is an adrenal mass for the differential diagnosis. If the clinical picture is fitting with pheochromocytoma, you can diagnose pheochromocytoma, and there is a mass here in the right suprarenal gland. This is T1, and this is coronal T2, and this is T1 post contrast with fat suppression. You see the mass is enhancing. Also, the pheochromocytoma in this example, you see the pheochromocytoma in the T1 and T1 out of phase. There is no drop of signal, meaning that this lesion does not containing microscopic fat. At some time, they use this sign, which is known as the light bulb sign, to diagnose pheochromocytoma, meaning that in the T2 weighted image, the lesion is very bright. But this sign is no more specific or pathognomonic for pheochromocytoma, and it may lead to many misdiagnoses. And we came to the adrenal gland, adrenocortical carcinoma, and this carcinoma is usually, from its name, it arises from the cortex, and it is usually a big mass ranging from 6 to 20 centimeter in diameter, and it shows a heterogeneous enhancement with areas of breakdown, and in about 1/3 of the cases, calcium can be seen within the tumor. Adrenal cortical carcinoma can spread by locally invading the liver or the spleen or the kidney. Then this is an example of a big mass in the left suprarenal gland with a large metastatic deposit in the liver. This mass represents an adrenocortical carcinoma. So you can see some ascites along the hepatic contour. Then one of the peculiar characteristics for the suprarenal gland masses is carcinoma can occur in the pediatric age group. And here you see a mass in a female child, 6 years old. The mass is big, affecting the region of the suprarenal gland, compressing the kidney, and you cannot see the closed sign, which means that there is an enhancing renal tissue along the border of the mass. If you see this sign, you know that this mass should be of renal origin. But here, the mass is outside the kidney and it is compressing the kidney. Adrenocortical carcinoma can occur in adults and also can occur in the pediatric age group. It can be functioning, contributing to some cases of Conn's syndrome and Cushing syndrome as well. And you remember that adrenocortical carcinomas are usually big masses. You see a huge mass on the left side. This is T1 and this is T2 with areas of breakdown. And this is T1 with contrast. And you see heterogeneous post-contrast enhancement. And this is a case of adrenal mass. On the right side, the adrenal gland on the left side is good, and the mass here is not sizable. It shows central areas of breakdown, and you may feel that there are some calcification inside. Then the differential diagnosis is wide, lipid poor adenoma, adrenocortical carcinoma, pheochromocytoma, metastasis, and so on. In here, you see a tumor, big tumor in the left adrenal region. This is the T1 weighted image, the T2 and the T1 post contrast showing heterogeneous enhancement. And the coronal images confirm that the tumor is outside the kidney It is above the kidney and is quite separable from the kidney. And in this example, you see a mass in the right suprarenal gland and the differential diagnosis as I have mentioned. Then adrenal deposits are diagnosed by two main criteria. Number one, the lesion in the suprarenal gland does not fit the diagnosis of lipid-rich adenoma. Number two, the patient is known to have a primary malignancy. If the two issues are available, then you can easily diagnose adrenal metastasis. And here you see two big masses in the region of the suprarenal gland. And you know, one of the most common primary malignancies that metastasize to the suprarenal gland is the bronchogenic carcinoma. But the breast cancer also, melanoma, can give metastasis to the suprarenal gland. And if you see a mass in the suprarenal gland which does not fit the diagnosis of lipid-rich adenoma, consider the list of the differential diagnosis, including metastatic deposits. But if you know that the patient had a primary malignancy, then consider metastasis the first possibility. And this is a patient with bronchogenic carcinoma showing a mass in the suprarenal gland on the right side, and the mass is of necrotic center. Then you consider metastasis. And this is a mass by ultrasound. And for the diagnosis, you should know that the patient had a primary malignancy. And in this patient, there are bilateral adrenal masses together with multiple peritoneal masses representing metastatic deposits. And this patient with bronchogenic carcinoma has two big masses in the right and the left suprarenal gland representing metastatic deposits. And this is also a case of bronchogenic carcinoma with metastatic deposits in the left adrenal gland as well as in the right adrenal gland. And this is an adrenal metastasis which is invading the inferior vena cava, and the invasion is best seen by ultrasound and not clearly seen by CT scan. Adrenal metastasis from melanoma, and you see a big mass on the left side and another big mass on the right side. And this patient had a huge bronchogenic carcinoma with right-sided pleural effusion, lung collapse, and bilateral sizable masses in the adrenal glands. And adrenal lymphoma is diagnosed by the same way as adrenal metastasis. The lesion in the suprarenal gland does not fulfill the criteria of lipid-rich adenoma, and there is a positive history of lymphoma elsewhere in the body. And here you can see two bilateral suprarenal masses and the differential diagnosis. If you do not know that the patient had non-Hodgkin lymphoma, the differential diagnosis will include metastasis and pheochromocytoma, adrenocortical carcinoma, and so on. And this patient had an adrenal B-cell lymphoma approved by surgery. This is the tumor, and this is the kidney, where a simple renal cyst is also present. After surgery, the cyst has been evacuated and the tumor has been removed. And this patient had a non-Hodgkin lymphoma of the testis, and there are bilateral suprarenal masses representing lymphomatous metastasis. The last mass in this group is the adrenal myelolipoma, and this lesion contains macroscopic fat or gross fat. You can see fat by the naked eye. And if you see a fat containing mass in the adrenal region, and you consider the diagnosis of myelolipoma. And the myelolipoma is usually non-functioning, but may be complicated by hemorrhage similar to the angiomyolipoma of the kidney. This is a rare lesion and it represents only 0.1 to 0.2% at the autopsy series, and in many cases it is incidentally found. It has no malignant potential. The diagnosis is made upon the detection of gross fat within the adrenal mass whether this by ultrasound, CT, or MRI. And here you see a suprarenal mass on the right side, and in the T1 weighted image it shows bright signal, meaning that it contains fat, and the T1 out of phase there is some loss of signal, meaning confirming the fat content. And this is an adrenal myelolipoma on the right side containing fat as well as other soft tissue structures. Then usually the adrenal myelolipoma is not functioning, but according to the literature, 10% of these myelolipoma are associated with endocrine disorders like the Cushing syndrome and Cone syndrome as well. In this patient with low back pain, and you see a fat containing mass in the adrenal gland on the left side, the right one is good. And this is also an adrenal myelolipoma on the right side, fat containing lesion. And this is the way how to deal with the adrenal myelolipoma. The small lesions with characteristic imaging are left without treatment. Intermediate imaging finding, you are not sure that there is fat, then you should have a percutaneous biopsy. Large lesions producing mass effect or lesions having hemorrhage, they are surgically removed. And this is an example of a very small fat containing lesion in the right suprarenal gland representing adrenal myelolipoma. Then we came to the adrenal cysts, and the cysts in the adrenal gland may be due to maybe of endothelial nature or epithelial nature or pseudocysts or parasitic cysts. And we want to say that the cysts are rare, but all the cysts of whatever etiology, they have the similar imaging appearance, meaning that you got a lesion which is containing water. Sometimes it shows marginal calcification, but this calcium does not indicate that this is hydatid cyst in particular, since the endothelial and the epithelial and the pseudocysts may have marginal calcium. And if the epithelial cysts are very rare, then you are in the differential diagnosis between these two types, the endothelial and the pseudocyst. The pseudocyst is not a true cyst. It occurs following hemorrhage, following infection, and the endothelial cysts are the true cysts. The complication of the cyst include hemorrhage, rupture, and infection, similar to any other cysts everywhere in the body. Then this is an adrenal cyst. If you see a cystic lesion containing fluid in the suprarenal gland, you say that this is adrenal cyst, and you cannot specify if it is pseudo or true unless you have the history. And this is adrenal lesion with peripheral calcification, and the lesion is unilocular with no enhancement. Then how can you know that this is a pseudocyst? There should be something in the history to lead you to the diagnosis of this. This example is to show that adrenal cysts, whether true or false or pseudo, they have the similar imaging finding. One of the differential diagnoses of this adrenal cyst, if it is located on the left side, is gastric diverticulum, since the gastric diverticulum is coming out from the fundus and it may appear here. But the differential diagnosis is easy, since if you give contrast media to the stomach, the diverticulum will fill with this contrast media. Typical appearance of adrenal cyst, a fluid containing mass with no enhancement, no calcium, no internal septations, and no mural nodules. And cyst by ultrasound will show hypoechogenicity with the acoustic enhancement similar to any other cysts. And this is an adrenal cyst, and on the right side, you see a fluid containing lesion with no mural nodules or enhancement. But if you see this typical appearance of hydatid cyst, a big cyst with internal mural, small cysts along the margin of the of the big cyst, and this is one of the classic appearances of hydatid, if you remember, as I mentioned in the lectures of the liver, spleen, and the kidneys. Then adrenal hemorrhage is the sequelae of trauma, but non-traumatic hemorrhage can also occur in overuse of anticoagulation or stress related to surgery, to sepsis, hypotension, and maybe idiopathic. 90% of the traumatic hemorrhage will occur on the right suprarenal gland because of the compression of the adrenal gland between the liver and the spine. And the hemorrhage, in most of the cases, if it is small, it will maintain the configuration of the adrenal gland as you see here. But in order to diagnose hemorrhage, and you should have the clinical picture and the history of trauma or history of surgery, or if you do not have a positive clue for the diagnosis of hemorrhage, and you will many times need to have a biopsy from this lesion. And this patient had a non-pleural mesothelioma which has been operated upon. This is before surgery. The right suprarenal gland was of normal size and configuration. After surgery, and you see the splint of the diaphragm, and there is some hemorrhage within the adrenal gland. And this is also hemorrhage. You can see that the hemorrhage is similar to fluid, but a little bit of higher density. And this should be included in the differential diagnosis of suprarenal masses. If there is a positive history of trauma, like in this case, then you may suspect that this is due to adrenal hemorrhage. And finally, adrenal infection is usually diagnosed by the presence of calcium within the adrenal gland. And the presence of calcium is highly suggestive of TB, which is one of the known infections in our country. And you can see spots of calcium in the left suprarenal gland as well as in the right suprarenal gland. One of the lesions which may lead to calcification of the suprarenal glands and the kidneys as well. This is a pre-contrast scan. You see dense calcium in the suprarenal glands and dense calcium in the kidneys, and this is the familial Mediterranean fever. This is an autosomal recessive disease with recurrent attacks of fever and serocytes, and it affects, of course, the population around the area of the Mediterranean Sea. And the attacks are accompanied by very high level of serum amyloid protein A. And in some cases, you can see soft tissue and vascular calcification. Then you remember that the hemorrhage, when it subsides, may leave some calcium within the adrenal glands. But our role as radiologists, whenever we are confronted by similar cases with absence of positive history or clinical data, we just describe that there is the suprarenal glands are not enlarged, there are no masses, but there are few spots of calcium, which may be the sequelae of previous infection or the previous hemorrhage. And in the era of intravenous urography, sometimes you can see calcium in the suprarenal glands as an incidental finding with no previous complaints. And this is a patient with adrenal insufficiency showing multiple calcific foci in both suprarenal areas. Then to conclude this lecture, if you are confronted by an adrenal mass that is incidentally found on non-contrast CT scan, you measure the density. If the density is less than 20 minus, if the density is that of fat, then you consider gross fat myelolipoma. If the density is around 0, minus 10 to plus 10 Hounsfield unit, then you consider the possibility of lipid-rich adenoma. Then inject contrast. If there is no enhancement, then you are dealing with a cyst in the suprarenal gland. But if there is enhancement and not only enhancement, but with wash out of more than 60% of enhancement in the delayed 10-minute scan, then you consider lipid-rich adenoma. Then, if you measure the density and it was above 10 Hounsfield unit, and then you inject the contrast. If there is enhancement and wash out of more than 60% of the enhancement in the delayed 10 minutes, can consider lipid-poor adenoma. If there is no washout, then consider the differential diagnosis, which include metastasis, pheochromocytoma, adrenocortical carcinoma, adrenal lymphoma, and the granulomatous disease. Then if you measure the density and the density is above 10 and you inject the contrast with no washout, if the patient had a known primary, consider metastasis. If the patient had a known lymphoma, consider lymphoma. If there is no known primary or lymphoma, then you should go to the biopsy to reach the final diagnosis. هذا وبالله التوفيق والحمد لله